We're going to be talking about how health insurance in America is a scam. And we're going to talk about the problems. Then we'll get a little into the technicals, made the situation significantly worse. And then we're going to talk about a possible solution combined with all these problems. So, health insurance basically operates on two principles. One, you being healthy, so never needing insurance. And two, once you are unhealthy, they pretty much operate by needing to control what they call utilization rates. There are some places that are antonyms for White River that are suing health insurance companies for providing too much health care to patients that are sick because it hurts their investment. The ideal person for insurance is someone who never gets sick, is otherwise healthy, but keeps their insurance just in case they get hit by a car crossing a sidewalk one day. That's the insurance company's dream customer. The flip side of that is the chronically ill or medically complex. Chronically ill just meaning like manageable diseases that are largely incurable, or complex diseases meaning you have one disease that is significantly expensive, or the medicines for these diseases are expensive, whether that be artificially caused or not, such as HIV, diseases to those effects. So insurance companies really don't care about you, and they don't care because they believe you are a captive consumer, which means everybody's going to keep insurance just in case because everyone has insurance. That's what everyone thinks. The trouble is insurance being useful if you actually need it. And if you actually need it a lot, insurance is, well, they like to manage their utilization. So because you're a captive, they don't really care about the price. And this is indifference to price. No one really cares about it. And because of that, they assume projections will continue to rise. And because no one goes without insurance, they assume no customer will leave. And this is how they have maintained the mentality that you're a captive consumer. There aren't really individual options that are cost effective. And so everyone pretty much uses their employer's plan, whether or not it be good or bad, because there are no free market alternatives. On the other side of this coin, the providers themselves are captives as well. They're going to graduate, I'm just going to be very generous here, and say they're going to graduate with 200 grand in student loans, possibly north of 500,000, depending on their residency track. Providers needing to pay back loans and sustain their lifestyle now that they're formally certified, board certified, etc., have to acquire customers. They acquire these customers by joining the insurance's networks. These insurance networks then place artificial administrative strengths, which is just purely to control utilization rates again. This side of the coin, the provider is captive because he's under the burden of debt to maintain enough customers to sufficiently support his lifestyle. At the same time, insurance companies are also every year decreasing the reimbursement that they are paying to providers. So they're captive to a network that continually disincentivizes them being in the network because they pay them less and less, and they have to employ more and more people to basically deal with the administrativeness of clawing the hands away from money from someone who actually provides value, of a provider of an insurance company. And this isn't just for doctors. This is physical therapists, occupational therapists, speech therapists. Oh my gosh, good luck. PAs, NPs, home health to a degree. They're all limited fairly intentionally to control this negative cash flow of where the insurance's money is going, because they need to be able to model quantitatively projections to sell to White River that the insurance company will increase every year in profitability. So this management is like increasing deniability, but it's also disincentivizing providers from being in the network because they're paying less and less every year. So why do I want to do business with someone who doesn't want to do more business with me? So the insurance company isn't really an insurance company anymore. They're selling access to a network, but they're selling access to a network on both sides. And if you've ever tried to find someone who's in network when you actually needed a specialist, you know that most insurance companies' network list on their websites are absolute garbage. So you'll spend all day calling to find someone you've never heard of that is the specialist that they will approve because they're only required to maintain a certain number of certain specialists for each very niche specialty. So the buyers of policies are keeping it just in case, and the providers themselves don't actually like the network anymore. So on both sides of the coin, we are both becoming customers who don't like what we're being sold. Luckily, it's not 1980 anymore. We can build a new system. We have Google. We can find a specialist on our own. You'll still need a primary care doctor, but just to navigate it, to know what specialist to go to, what's the benefit if there is no benefit of insuring against just in case? So this leads to another problem because so many people use employers as their point of access to insurance networks. People that are no longer working, retired, or unable to work end up on government programs, Medicaid, Medicare. But these are generally the sickest people in the country. So you have an insurance company who's insuring basically the healthiest people. And then once they're not in the benefit of health insurance anymore, the government picks them up. So the majority of people will incur the most healthcare insurance costs to them, or healthcare costs in general, within like the last 10 years of their life. And the government is just getting hammered because you're getting complex care or you're getting chronic care. And these last 10 years, diseases will start knocking on each other. Heart failure will inevitably lead to kidney failure. And once kidney failure has occurred because of heart failure, you're going to get some like fusion interference in your lungs. So that's just a broad statement that those three systems are so closely connected that you're going to eventually bring down all three systems. And that's a chronic illness and an elderly kind of disease pathway. But again, by the time it becomes a problem, the cost is going to be on the government. So if people don't like the cost of their insurance and doctors don't like their networks that they need to get customers, and we have Google now, these systems were built when phone books were needed. This system doesn't really need to exist anymore. If you guys want to skip ahead, we're going to get into the technicals. Targeted acquisitions of hospitals are what's now occurring. There is restrictions on who can own hospitals. And this was brought about under the Affordable Care Act. So doctors are the main group that are essentially ineligible to own hospitals anymore. Like, we don't tell carpenters that they can't own cabinet companies. We don't tell mechanics that they can't own dealerships or repair shop. We don't tell chefs that they can't own restaurants. We do tell astronauts that they can't own rocket companies. Very few exceptions. But they are the only profession that is one of the most highly educated and highly skilled, who are, whether as contract employees or not, will never be an owner. They are only going to be employees under this provision of the ACA, Affordable Care Act. And if you can't move into being an owner, you'll be an employee forever. The other problem is pharmacy benefit managers. These people, they're manufacturers of medications, and they are retail sellers of medications. Pharmacy benefit managers negotiate the price in between the manufacturer and you. They mark up the price, resell it, keep a percentage of the profit of the markup, and otherwise. The manufacturer doesn't really care. They just want to sell it at the price that's profitable for the manufacturer. They don't care about the logistics gain. They do care about the patient load. Sometimes you'll run into that with Wilson's disease, where there's basically not enough patients for certain diseases to making the medication itself profitable. And these guys are just railroading everyone. I mean, congratulations to Arkansas for destroying PBMs in the state of Arkansas. And when it did that, did the companies that were using PBMs change their practices, stop using their PBM networks? No. There is a 3-letter pharmacy company that is fairly known nationwide that as soon as Arkansas was not allowed to be a PBM anymore, closed their businesses. And just the problem is the network provider for someone through a health insurance agency in that state. So now they may be forced to go to an out-of-network pharmacy because the void that attempting to take care of patients like the state of Arkansas did is going to cause. And you got to start somewhere. I mean, you're going to get a black eye eventually, but they just abandoned 1 out of 50 states of profits because they didn't get to do business, artificially inflating the prices between the manufacturer of a drug and the person who gives them money. Under the Affordable Care Act, health insurance companies, they were limited by a percentage of what they were allowed to pay their employees for total, we'll say. So we're just going to say that this percentage is 10%. So that would make your max payroll at this health insurance company $300,000. But if you sold $30 billion worth of services, well, then your payroll allowance is $3 billion. The health insurance companies began to acquire pharmacies, and then they also began to acquire pharmacy benefit managers as well, because they wanted to drive up total cost of outputs. At the same time, they wanted to drive down the cost of inputs. So it wouldn't matter the price of a medication was acquired from a manufacturer for. It would only matter the cost that it was sold, because this cost sold would be considered part of a patient care plan. And when the retail pharmacy sells this, it would drive the total cost of goods sold, and then would also, by moving this large number of healthcare costs, increase 10% that health insurance companies could charge on their 10%. So acquisitions started to begin to occur. Part of their projection was stated that with the Affordable Care Act, there would be more individuals eligible for healthcare insurance, which would drive pharmacy sales and usage. But in reality, in my opinion, it was more of a confinement. If you didn't control the cost outbound of the health insurance company, then you could not control the payroll. So they vertically integrated the business upward and down to reduce input costs to the health insurance company or input costs to the pharmacy. And then they expanded cost output to maintain this payroll percentage. While they were doing this, they started reducing, I forget which year, they started reducing provider basically payouts or payments for codes or diagnostic codes. So they're again attempting to control in a controllable manner, because people with heart disease aren't going to stop paying for their medication, but they're also controlling the providers you go to see by controlling what's left after what they agreed to pay in network is paid, and you're left with the remainder of the bill. It's driving doctors to compliance rather than efficacy on healthcare delivery. And any system that focuses on compliance rather than efficacy will not be able to maintain efficiency. So how well the thing runs. And we don't have a chance at this rate of the system even being able to return, in my opinion, to efficiency long term, because of just, this is wild. Like, how far can you push a thing broken? Just insane. All right. So big wave for everybody skipping along in the video. Welcome to the solution on how to fix the health insurance scam. If you're still here, you're probably someone who works in the healthcare industry or someone who really hates their health insurance. And if you're still here, we're going to have to break some things in order to make it better. Because these insurance companies are owned by corporations and they only care that the projectable model shows the business increasing in profitability. This is quantitative, number crunching. We need to make the line go up. Well, people value their life on how the quality of their life is. And these two systems just can't live together. With that being said, somebody's going to have to come to the table. And that makes us have to make them come to the table. Step one is breaking insurance. And I won't be the one to break it, but I can tell you how. To force these people to the table, to negotiate, we have to create and incite an event. Because begging them for help doesn't matter, because they don't care. They don't care. They want you healthy, underutilized, and if you're too sick, you're the government's problem. We have to create the environment for change. And the way to do that, there will be people in the event that will not survive. But the system itself is becoming so unusable, that you have to ask the question, are more losses today worth more saves later, or more losses over time worth keeping what's broken? And I think if you're still here at this point, we know we need to fix it now. So let's break some things. A nationwide strike by bedside nurses would disable nearly all functioning healthcare industry, period. The largest worker base of the U.S. healthcare system are nurses, and they are really the only ones who have the chance of intervening because no one else has the numbers to stop what's happening. So a nationwide nursing strike should be planned. The nurses should prepare reserve cash accounts for 3 to 4 months without work. The strike should begin on May 15th. This reduces losses of life of seasonal diseases. The flu in kids, pertussis, croup. While we intend to break the model, there's no point in breaking the model in January because that's when the most preventable diseases are occurring in this. So healthcare stops functioning. The need for health insurance to operate a system that is not functioning is useless money spent. So after the nursing strike begins, beginning June 1st, after May, the strike will begin May 15th, individual consumers of health insurance companies disenroll themselves of their health insurance. These rates are negotiated in the open enrollment period. So the healthiest people will be at home in the summer when seasonal disease is at its lowest. Children will be home, so contagion through proximity to other children will also be low. And this pretty much maintains itself through August. But once you disenroll from health insurance is when the health insurance profitability model basically self-destructs, because anyone who isn't going to disenroll is going to be the sickest, which means they're going to have to incur the highest amount of cost with no volume and scale of economy to cover the cost of these sickest people. If you say you're a healthcare insurance company, let's find out if you are, because I can assure you, as soon as you become a $3 billion revenue company instead of a $4 billion company, you'll complain. And every one of us who's worked in healthcare before, we won't watch. We won't mind you crying because you lost $1 billion. So this basically breaks their model, which is going to force them to come to the negotiating table. But in reality, you don't even really want to talk to them because just negotiating a better price for a system that doesn't work doesn't really make sense. It's just a band-aid. So what you're going to have to do is force legislation to occur. And you have 6 months to do that because the health insurance company is going to just get beat to death. Initially, they're going to get beat to death on loss of cash flow from people not being payers into the health insurance company. Then they're going to get hounded on negative cash flow because the sickest people are draining their resources. And then you're going to have people with put and call options who get margin called. And these are going to be like the White River people who are seeing the line not go up because the captive consumers have had enough. And the line's going to start going down. And they don't know where the line goes down on a captive consumer market where people refuse to be captives anymore. They're going to begin selling, or in the dumbest case, they're going to try and cover their position, which would be even stupider. You could really force like legislative congressional action in that window. The government would try and do some things to basically everyone. One of these is going to be a temporary restraining order. And it's basically going to say that you're an essential service. You're forced to go to work. You do not have a choice. And that'll be for the medical people who are on strike. But if you don't obey the temporary restraining order, what are they going to do? Take you to jail for 30 days for contempt? Well, guess what? You're still not in the hospital. You're still not working. It's this useless threat. And you have 4 to 6 months of cash reserves. So again, they're forced to the table. TROs at this scale really don't function. Temporary restraining order as a TRO. It would require the federal government to take over hospitals, which that won't happen. That would be the only way the government could really combat this at like a meaningful scale without reform. But the FAA took over flight controllers in their strike. But they just don't have the scale to either buy all of the hospitals or cover the payroll of all hospitals. The government's options here are basically come to the negotiating table acting like they're the strong guy and then realizing they're not because all of their other cards suck. Solutions to health insurance model. We don't have time for really a bunch of dumb Congress administrators to invent a plan that's worse than what we had before pre-Affordable Care Act. And we don't. That's already not working because all they did was supercharge health insurance companies, pharmacy benefit managers, and pharmacies into these like mega vertical acquired corporations. So thanks. We'll pass. Please don't try and tell us what works because you really have no idea. We don't have time to invent one ourselves either as healthcare workers. What's the plan? The plan is to adopt a plan from somewhere else that already works. There are a lot of places we should not look on how to reform healthcare delivery, which is basically what we're talking about. Because health insurance controls healthcare delivery. Some countries that systems function extraordinarily well are Singapore's 3M plan, which did really well. And then if you went with Singapore, you would basically forcefully enroll every household in America into a health savings account. And this would become an investment vehicle that people, instead of Medicaid, Medicare, taking that percentage from your paycheck, it would go into your family's own HSA, which creates savers, and you could use these funds for healthcare needs. Well, if everybody has an HSA and the program is managed by the government, then the network is the HSA. So health insurance networks become useless. More or less, they would dissolve. This, in my opinion, I prefer the Singapore 3M plan. They are even required to, if you go to the Singapore Ministry of Health, you can Google by bell curve distribution, which is like 10% will cost this much, 30%, 50%, 80%, etc. And it'll tell you the price that 30% of patients paid $20,000, and at 50% they paid $24,000. So it understands the cost and the even distribution, and you can't just go into a health situation not knowing the price tag, which is currently what we really have, before you get services rendered to you. There is the Taiwan plan, which would be Medicare for all, no other insurance companies ever. This would work as a system it is unlikely to pass anyone in Congress because no other insurance companies would exist, basically under the Taiwan plan. It's an option. Is it probable? No. There is the current option, which we currently have designed, but you add a layer in, and this makes health care. Basically, right now we have sick care. When you're sick, you get to use your health insurance. But it's because they're incentivized to take care of healthy people only. So then sickness is only the priority. If we keep the current model, you would force health insurance companies to also provide a minimum of $250,000 of life insurance on the individuals of the plan. So for a family plan, on a household of 4, they're now at $1 million in health insurance, and they also have $250,000 of life insurance liability. So your health insurance company becomes extremely disincentivized to allow people to gradually become sicker and sicker. Because sometimes you'll be allowed to become sicker and sicker if you're near becoming, if they believe that you're a futile effort to, if there's no intervention that's going to save you within 5 years, you just won't get help from your health insurance company. They'll just deny the claims or delay it as long as possible until you're not here anymore. This would correct that behavior quickly. I doubt that will pass. So, is it a solid option? Yeah. Does it make logical sense? Yes. Which means it's probably too difficult for Congress to understand. So we can go ahead and scratch this one off as well. So the final one is the private-public blend, which is the most realistic option pretty much anywhere. Because it could unburden the government, which is what congressmen would be voting for. It would unburden the government of only taking care of the sickest people. You would need to remove Medicare, and everyone would become eligible for Medicare. And when you reduce that, you also want to reduce individuals from paying for plans themselves. Because if you do that, then you're requiring a 1-day-old kid to pay $100 a month. This is just not reasonable. You would have to insure homes under this Medicare for All plan at or around $200 per household. There is some reasons you would do that. Mainly, this is going to put the floor of family health insurance policies at $200, which means every health insurance company that insures a family plan will be forced to come to the floor or near it. Your first Medicare would be like $200 a month. You could pay for a private Medicare Advantage plan secondary to that, but everybody's going to pay for Medicare, right? This is that private-public blend. But the $200 per household forces the majority of households to reprice and say, well, I'm never actually sick. I don't have complex care. I don't need XYZ. This is really just a just-in-case health insurance. You would reprice the majority of health insurance because the people they would be stuck with would be the most sick in that window of when Medicare would not have normally have covered them. Now, the government has the healthiest people in this Medicare household, $200, and it also holds its Medicaid people, the sickest of us all. You're going to cover the cost burden to the government of these people taking care of healthy people, funds taking care of unhealthy, the most unhealthy. That would be the selling point for Congress accepting a version of this plan. The reason that you would allow that Congress would go this plan and we would also go for this plan is because you're going to take your health insurance premiums down to $200 per household, which is also going to make it to where there's no disincentivization. There's no penalty for having larger and larger families. And 2007 in America was pretty much the last largest population year ever. We've not had kids in greater numbers since 2007, which was because of the economy. You basically need to spur a way to cover the losses that the government's going to have from more and more people becoming sick because they're elder and there's insufficient numbers of young people to cover it. And the only way you're going to get enough money is if the young people start paying for it now to cover their parents. Because when those young people get old, they will be the ones that have already paid in to cover. Australia's got a pretty good private-public blend. Chile has a private-public blend. I'm not sure how well that runs. But you could also, so that's the Medicare. Behind that, your accessory insurance would cover your whatever we determined is not eligible in Medicare. These are the 4 pathways. I'll drop some links into these. Someone who's already made some videos about these countries' health insurance plans, and because I don't feel like making the same video twice. And you guys let me know. What do you guys think? Because I think what we have now isn't working, and if they don't want to make what works, we'll make what we have right now not work. So are we gonna break things a little bit, or are we just going to keep getting railroaded by our sick insurance that we currently have? Who only cares as long as they can deny, delay, and hope you always pay.